a very kind introduction. Good morning, everyone. At the outset, I would like to thank Dr. Bansi and team DiaObecon for this opportunity. So, as you know, I'm going to speak on sarcopenic obesity, a concern for Indians. And I know I have 15 minutes, but I'll try to do justice to give you the concept why it is important for sarcopenic in Indian setting. So we know that India is a country with huge prevalence of diabetes, and what I'm showing you is the data from ICMR INDIAB study. And I'm thankful to ICMR and Dr. Mohan for sharing these slides. So if you look at the data, we have more than 101 million people living with type 2 diabetes, in India, which accounts for almost 11% of the adult population. But the study also showed that we have a huge prevalence of obesity, and almost 30% of the people, adult population, is living with obesity, and almost 40% of the population is living with central obesity or abdominal obesity. And this is one of the major challenges. Now, before the ICMR INDIAB was published, this was a publication in 2017 when they had completed only 15 states. And if you look at the prevalence of diabetes, obesity in 5 highest prevalence states, these were the states of Manipur, Chandigarh, Sikkim, Punjab and Delhi, and these were also the states with highest prevalence of central obesity, and these were the states with highest prevalence of diabetes also. So there is a strong association between obesity and type 2 diabetes, and there are number of studies have shown that once there is obesity and central obesity, there is increased risk of developing type 2 diabetes. Now, second thing is sarcopenia. What is sarcopenia? Sarcopenia is derived from a word sarx and penia, which means loss of flesh or loss of muscle mass. And this usually describes the age-related loss of skeletal muscle mass and function. The important thing is, once you see, let me use the cursor here. So once you are seeing a normal muscle picture, there is hardly any fat here. But once you lose muscle mass, not only there is loss of muscle mass, there is increase in adipose tissue around the muscle and within the muscle. So sarcopenia is associated with both loss of muscle mass and increase in fat. So sarcopenia is decrease in muscle mass, more so in the lower extremities. Simultaneously, there is increase in visceral and inter or intramuscular fat. Usually it is age-related, starts after 30 years of age and increases, there is increasing decline after 60 years of age. And now we also know that there is a decrease in strength, muscle strength and performance, which are equally important in defining sarcopenia. So sarcopenia is defined basis of 3 criteria: low muscle strength, low muscle mass quality and low physical performance. If you have one, it is probable sarcopenia. If you have both of them, it is confirmed sarcopenia. And if you have low physical performance, it is severe sarcopenia. Now, what is sarcopenic obesity? Sarcopenic obesity is characterized by a combination of obesity, which is defined by high body fat percentage, which is harmful for health, and sarcopenia, which are occurring together. It's a unique clinical condition which is different from obesity or sarcopenia alone, and this is due to existence of a bidirectional pathogenic relationship or interaction between body fat mass accumulation and loss of skeletal muscle mass and function. And there is negative interaction between obesity and sarcopenia, leading to increased risk of developing cardiovascular risk and metabolic issues, which are more than what would be expected by combination effect of these two conditions. ESO and SPEN have defined sarcopenic obesity as a coexistence of obesity and sarcopenia, and it is characterized by high body fat percentage and also low skeletal muscle mass along with muscle function. So it is not just low muscle mass which is important, there is loss of muscle function also. So a person with obesity may have normal muscle mass or low muscle mass, and a normal person, person with normal body weight also may have low muscle mass and high excess of fat. So this is a condition when there is high adiposity and low muscle mass. These two criteria are very important with loss of or decrease in the muscle function. So sarcopenic obesity is more frequently present in older adults, but not necessarily limited to this condition. And primary condition, it may be a primary condition or a secondary condition which can happen in people with diabetes or other chronic diseases also. Now, there is a very complex interaction between two. Obesity drives sarcopenia and sarcopenia drives obesity. What happens is, once there is sarcopenia, person has muscle fatigue, decreased ability to exercise, and there is disability. So lack of muscle usage leads to increased accumulation of fat. Increased accumulation of fat leads to increased inflammation, increased intermuscular fat infiltration, leading to insulin resistance, poor muscle quality, decreased muscle mass, further worsening sarcopenia, and sarcopenia worsening obesity. And one more important thing that you have to notice here is that it leads to increased insulin resistance. Both sarcopenia and obesity are contributing to insulin resistance. What is causing sarcopenia? There are a number of factors like hormonal changes with aging, the increased inflammatory status in the aging muscle, the chronic conditions that can be there with aging, neurological disorders, genetic predisposition. Old age is, of course, the major factor. With aging, there is poor diet, there is decreased protein intake, there is decreased physical activity, and there is central obesity which can be there. And there is loss of proper mitochondrial function with aging. Now, some of these things are also risk factor for developing diabetes, like mitochondrial dysfunction, obesity, decreased physical activity, poor diet, aging. All these contribute to insulin resistance and aging also. Now, once there is, unhealthy eating habits, lack of exercise and aging, there is increase in fat deposition, ectopic fat deposition and insulin resistance, and there is decreased metabolic rate, physical activity and anabolic hormones. So there is both accumulation of fat, which leads to decreased mobility, increased lipotoxicity, increased inflammation in muscle, and increased accumulation of IMAT or intramuscular adipose tissue. On the other hand, this leads to increased inflammatory status, increased leptin, decreased adiponectin, and further increase in the muscle mass. So there is a close interaction, one driving each, and they all lead to increased risk of diabetes, cardiometabolic disease, and so on. So impaired muscle health can contribute to development and progression of diabetes, and we know that aging skeletal muscle mass is associated with mitochondrial dysfunction, activation of RAS, PTP pathway, autophagy, sarcopenia, all contributing to insulin resistance. Now, there are potential mechanisms for sarcopenia leading to diabetes include altered glucose disposal, increased inflammation, oxidative stress, and intramuscular adipose tissue. Reduced muscle mass reduces glucose disposal because muscle is the site of energy expenditure, and with aging there is reduced antioxidant capacity and increase in the oxidative stress at muscular level also. And there is dysfunction of muscle because of the low muscle mass, inflammation, and also the decreased physical activity. And all these are contributing to development of insulin resistance. Adiposity is also, increasing with age, decreases the body mass, the basal metabolic rate, reduces postprandial energy expenditure, and decreases fat oxidation. Reduced fat oxidation coupled with sarcopenic obesity is associated with increased insulin resistance. Adiposity, we know, is again, one of the major issues for muscle mass and increased deposition within the muscle, and it is proposed that IMAT secretes protein that modifies muscle's extracellular matrix because it has local influence there, leading to increased insulin resistance, increased ectopic deposition of fat in muscle and liver. IMAT triglyceride lipolysis releases free fatty acids locally, again leading to increased lipid accumulation and increased insulin resistance. And in addition to insulin resistance, IMAT causes inflammation, which is one of the possible mechanisms leading to increased risk of diabetes. So both obesity and sarcopenia are leading to increased risk of diabetes, and we know that diabetes is major challenge in India, and that is why sarcopenic obesity is a major concern. And we know that obesity in India is rapidly increasing, and we have Asian Indian phenotype characterized by higher body fat and lower muscle mass. And this is one of the reasons we have morbidity, comorbidities or mortality or diabetes and cardiometabolic conditions occurring at lower level of BMI in Indian setting. So this is why it is a major concern. So take-home message is that there is high prevalence of obesity and type 2 diabetes among people in India. We have Asian Indian phenotype, which further predisposes us to higher risk of getting diabetes, which is again already a epidemic situation in India. Asian Indian phenotype is characterized by high fat mass and low muscle mass, and we need to recognize sarcopenic obesity and its management as important concern in Indian population. With that, I conclude my presentation. Thank you so much. I would like